Hello everyone, good evening. So let's get started with question number 1. Uveitis, many people are saying. So we'll take one question related to the uveitis also. Okay? Alright, so see this question, a 72-year-old woman. She is presenting to the emergency department with 1 week. There's only 1 week history of double vision looking towards the right. So diplopia looking towards the right means some muscle which has action towards the right gaze, right? So I'm telling you line wise so that you know how to interpret. So that means some problem with the right gaze. It could be any muscle. Right. Okay. Now when she looks straight at you, the eye appears deviated medially. So when she is looking straight like this, okay, which eye they are saying the right eye appears deviated. So this is the right eye and this is the left eye, and right eye is deviated medially, left eye looks to be normal, right? And okay, apart from a mild headache at the onset of her symptoms, she's otherwise feeling well. Past medical history may controlled hypertension and hypercholesterolemia. So she is actually a known case of hypertension, hypercholesterolemia, but it is under control. She's a non-smoker. Ocular movements demonstrates failure of the right eye to abduct beyond the midline. And also there is a diplopia when looking towards the right. So there is some problem, as I told you. There is some problem in this right gaze like this, and she's not able to move her eye towards the right. So right, that means she is having the abduction deficit in the right eye. Okay, now what is there? We have got all other movements appearing normal. We have got full neurological examination that is also revealing no abnormality. Pupillary reactions are normal. Now can you tell me, what can you interpret if they are saying pupillary reactions is normal and there is no ptosis? Which nerve you can say is normal? If I am saying that pupillary reactions are normal and there is no ptosis, can you tell me this? A very simple thing I have asked you. If they say pupillary reactions normal and there is no ptosis, then which nerve you can say is actually okay? Can you tell me that? Visual acuity also normal. So which nerve can you tell this? They are telling you about the different nerves. We know that all the extraocular muscles are supplied by third nerve except for SO4 and LR6. Except for the SO4 and LR6. Yes, it is the first question. We are going reverse way. Very good, Ankita, Kamal, and Ashwarya. Very good. If I am saying that pupillary reactions are normal, pupillary reactions, so which nerve I am checking? Plus, I am saying that there is no ptosis also, right? Ptosis means LPS muscle. So both of them actually involve the third nerve. So very conveniently, I can say that third nerve is intact. Okay? Then they are saying visual acuity normal. So which nerve is normal? If I am saying visual acuity is normal, if I am saying that the visual acuity is also normal, that means I have normal second nerve also. So second nerve we have checked, third nerve we have checked. Now we are left with the fourth nerve and the sixth nerve. Now this person is having the failure of abduction. The failure of the abduction, which is the function of the lateral rectus, right? And this eye is not able to go into the right gaze, having a convergent squint, not able to go beyond a certain limit. It's not able to cross the eye. The central midline, it's not able to cross. Yes. So, okay. Cardiovascular system normal, BP 124 by 86 hai, with a blood pressure of 124 by 86. Which of the following is the most likely diagnosis? So what do you think is the answer? Is it a Duane syndrome? Is it myasthenia gravis? Isolated right sixth nerve palsy? Ya फिर thyroid eye disease, and why? Now let us start with the option number D, thyroid eye disease. Now if I talk about this thyroid eye disease actually is the most common cause of the proptosis. It is the most common cause of the proptosis, and that too in the adults. Most common cause of the proptosis in the adults. So if I talk about the thyroid eye disease, its presentation is not failure of the abduction. Its presentation, the first thing that we get is actually the retraction. The first thing that we get is the retraction of the upper lid. This is the first thing that we get, and then the second thing that we get is the proptosis in the adults one by one. So when I am having a patient of thyroid eye disease, I am actually expecting the retraction of the upper eyelid. I am expecting the proptosis, and along with this, there will be squint. But what kind of squint that person will have? That will have the restrictive kind of squint, and mostly it will be bilateral. Here I am having unilateral. Plus, what is the most common muscle to be involved in the thyroid eye disease? If I am expecting thyroid eye disease in the person, I am expecting IMS Lucknow, right? So that means I am first expecting the inferior rectus to be affected, then medial rectus, then superior rectus, and then lateral rectus. That means by the time this lateral rectus will be affected, which muscles would also be affected? These also. While they are saying that all these are intact, the only problem this person is having is failure to abduct. So that means only lateral rectus is affected. So are you understanding why it's not thyroid eye disease? Then the C option is isolated right sixth nerve palsy. So obviously it could be there. If there is a right lateral rectus palsy, obviously there will be a convergent squint. There will be a failure of the right eye to abduct. So that could be there. Now what about the myasthenia gravis? What is the most common ocular abnormality in myasthenia gravis? Can you tell me this? Another question. What is the most common ocular abnormality in the myasthenia gravis? Very good. Very good. Sonali, very good. Surbhi, very good. Chinmay also, right? So, why it is not myasthenia gravis? See, when I talk about the ocular myasthenia gravis, the most common finding that we get is actually the ptosis, which they have bluntly said that this person is not having the ptosis, right? And secondly, we are not having any nerve palsy in cases of thyroid eye disease. We are having the involvement of the muscles. It is the fibrosis of the muscles that we are having, restrictive kind of squint we are having. So again, it's not the thyroid eye disease, not the myasthenia gravis. Duane's retraction syndrome is again a restrictive squint. It is again a restrictive squint. So again, I can say that it is not the case of Duane syndrome, and answer will be isolated sixth nerve palsy, right? Now somebody was asking about the internuclear ophthalmoplegia. I'll be talking about this because hello Avinash. So finally Avinash is there. Where you have been so many days, Avinash? I thought Avinash is lost somewhere. Okay. So, we'll be talking about an important topic because that needs revision just before it. Yes. Yes, it's ptosis. Very good. The most common ocular involvement in the ocular myasthenia gravis is the ptosis, right? Now, let's talk about the internuclear ophthalmoplegia. I think this is an important topic and must be revised before the examination. So, let me draw the two eyeballs here. This is the important part of your gaze palsy because a similar kind of question can come related to internuclear ophthalmoplegia. Semester examination. Don't get lost too much in semester examination, Avinash. Okay. So this is there. Now this is the right eye and this is the left eye. Okay. Now I'll be drawing the muscles there. Now try to understand it. This is your lateral rectus, medial rectus, lateral rectus, medial rectus. Okay, na? So right lateral rectus, right medial rectus, left medial rectus, and the left lateral rectus. Now, what do you mean by gaze? The person can see in one gaze. Person can see in a right gaze. Person can see in a left gaze. So let's see, talk about one gaze. Maybe we talk about the left gaze. Okay? Now, when the person wants to see in the left gaze, what does it mean? Left eye will see towards the left and the right eye is also seen towards the left. So, which two muscles are involved? This is actually the levoversion. Both eyes are looking towards the left. That means levoversion. So, that means we have got left lateral rectus and the right medial rectus. These are the yoke muscles. During the levoversion, during the left gaze, my left lateral rectus and the right medial rectus should contract simultaneously. Only then I would be able to see the left gaze. So, how they are connected? So, let's see that. Now, we know that this medial rectus will be getting the innervation from the third nerve. So, this is your third nerve nucleus. Okay? Now, this lateral rectus will be supplied by the sixth nerve. So, this is your sixth nerve nucleus. Okay? We have got the sixth nerve nucleus like this. So, we have got internuclear ophthalmoplegia. Ophthalmoplegia means the palsy in the fibers between the two nucleus. So, what are these fibers between the two nucleus here? These fibers are your medial longitudinal fasciculus which are joining this third nerve as well as the sixth nerve. Now, what is happening? We have got one more center which is present here. This is your PPRF. PPRF. So, what is this PPRF? PPRF is your parapontine reticular formation. Parapontine reticular formation. This is your the horizontal gaze center, where full name is RI, that is your rostral interstitial. These are also questions which were once asked. Rostral interstitial parapontine reticular formation, while MLF is your vertical gaze center. Vertical gaze center. Okay? So, two important things. We have a horizontal gaze center and we have a vertical gaze center. Okay? Now, this PPRF is sending the innervation to this MLF as well as to this sixth nerve nucleus. Okay? Now, this PPRF is controlling the horizontal gaze. That is why it is directly sending the innervation to the sixth nerve nucleus also, and on the other side it is sending to MLF. MLF will go to the third nerve nucleus and third nerve nucleus will go to the medial rectus. Now, suppose I have a problem. Suppose I have a problem with this MLF. Now, let us try to assume if I have a problem with this MLF, what will happen? This MLF is not going to send the innervation to this third nerve nucleus and this medial rectus is not going to work. Now, since right medial rectus is not working, so I will have right adduction deficit. Right adduction deficit is very, very clear because right medial rectus is not working. Now, this PPRF is not sending the innervations to MLF because there is a palsy. So, what is happening? There is an increased innervation to this sixth nucleus, due to which what is happening? This lateral rectus is normal. So, I will have the abduction. There will be no deficit. But because there is an increased innervation, there will be nystagmus. So, there will be left abduction nystagmus. So, that means in general, I can say that when I have MLF lesion, whenever I have the MLF lesion, I will have ipsilateral. Ipsilateral matlab same side. Ipsilateral adduction deficit. I will have ipsilateral adduction deficit and I will have contralateral. Contralateral matlab opposite side abduction nystagmus. Abduction nystagmus. Ipsilateral adduction deficit है, contralateral abduction nystagmus. Now, for example, if I say right MLF lesion, if I say we have a right MLF lesion, then what I will have? I will have right adduction deficit. So I will have a right adduction deficit plus we will have left abduction nystagmus. Left abduction nystagmus. But we will have left gaze palsy. If you look in terms of the palsy, it will be a left gaze palsy. Matlab, if problem is lying in the right MLF like this, then there will be a problem with the right medial rectus. Right medial rectus will not adduct and therefore person will not be able to see in the left gaze. So problem will be in the right MLF but in the left gaze. So if it is asking you about the gaze, it will be contralateral gaze palsy. Now, if I have a problem with this PPRF, let us suppose now the problem is with this PPRF. What will happen? Now let me explain you here. If I have a problem with the left PPRF, okay? So what will happen? Due to this left PPRF, there will be left abduction deficit. Why? Because this PPRF is controlling the lateral rectus, 6 nerve nucleus of the same side. So I will have the left abduction deficit. Now this PPRF is also sending the innervation. In the bracket I can say due to the 6 nerve nucleus. Then it is also sending the innervation to the MLF. Which side? Right side. Now because I am having a problem with the right MLF, now what will happen? I will have the right adduction deficit. So left ka abduction deficit, if you see here like this was your right eye and this is your left eye. So if I am having a problem on this side PPRF, so this is gone due to 6 nerve nucleus, other side pe MLF, so this also gone. Okay? Now what is happening? Suppose I am having the left PPRF. Suppose there is a third option. I am having left PPRF plus the left MLF lesion. Okay? If I am having a lesion of PPRF as well as MLF also on the same side, then what will happen? Now again this component will be same. I will have left abduction deficit. Then I will have right adduction deficit. Okay? Right ka adduction deficit will be there. Now plus I am having the same side left MLF. So due to this left MLF, this is due to this PPRF lesion. Now due to this left MLF, what I am having? I am also having the left adduction deficit plus I will have right abduction nystagmus. Right abduction nystagmus. Now try to see it on pictures. See this. This was your right eye. This is your left eye. Okay? Now I am having left PPRF problem. This is a problem. So this muscle will not work. And it is also sending the innervation to this medial longitudinal fasciculus. So this is also not working. Okay? Now I am also having a problem here in the MLF. Now due to this MLF, this is not working. Okay? So other side PPRF will send increased innervation to the 6 nerve nucleus. So this is present. There will be abduction nystagmus. Okay? Now see this. What are the movements which are absent? So this is your half. This is your half. So this will become 1. And this is also half absent. So this is 1.5. So this is actually called as 1.5 syndrome. So this is the simple 1.5 syndrome that you get due to the lesion of the MLF plus the PPRF. While if I am having the lesion only of the MLF, medial longitudinal fasciculus, which is actually the joining fibers between the two nucleus, the third nerve nucleus and the sixth nerve nucleus, then this is called as internuclear ophthalmoplegia and the opposite gaze palsy. Now see if you have understood this. Is it very, very clear? 1.5 syndrome, internuclear ophthalmoplegia. Very good. So give me a thumbs up if you have understood the internuclear ophthalmoplegia. I think one question done for you. I surely think that there will be a question related to the nerve palsy or internuclear ophthalmoplegia, 1.5 syndrome. These things will be there. So tell me if you've understood this, guys. Yes or no? Okay. Yes, ma'am. Very good. All right. So see one more question now. Here we have got a 85 years old man. Very good. Everybody is yes. Very good. Awesome. So see the other question now. 85-year-old man presents with a rash over the forehead, the tip of the nose, left eye pain and decreased vision. What are you thinking? What are you thinking? A rash over the forehead, tip of the nose and eye is also involved. So what are the divisions which are involved here? If I am having the forehead, this is your frontal division. Tip of the nose is your nasociliary division. And eye means we have lacrimal division. Lacrimal division is there. Frontal, lacrimal and nasociliary. What are these divisions? Can you tell me? Rostral interstitial medial longitudinal fasciculus is the specific part of that MLF. Okay. So what are these divisions? These are the divisions of the ophthalmic division of the fifth nerve. Okay. Now we also have what? We have got fever, malaise. We have got fever, malaise, a burning sensation in the area around the eye for the past 5 days. So we also have the systemic features. Systemic features. Now this is important to know that we have got systemic features because in certain areas we do not have the you can say in certain diseases we will not have the involvement of the systemic features. In certain we have. Now on examination, we have got a vesicular rash in the periorbital region. Left eye is red, chemosis of conjunctiva. So there is actually conjunctivitis. There is a pain. So we can say there is involvement of cornea. If you remember in the last sessions, we have discussed that if I say pain means corneal involvement. And cornea shows dendriform ulcers. Now, when we have got true dendritic lesions, it is dendritic ulcers. Dendriform का जो proper meaning है, dendriform means it is pseudodendritics. Now, don't go with the particular things because sometimes they even say dendritic ulcers also. But by chance here, the word used is dendriform. Dendriform means pseudodendritic. Or more specifically, I can say that it is like dendritic. They are not exactly dendritic, but they are like dendritic ulcers. So that means we are expecting the viral keratitis here. Yes, when I'm saying it is dendritic form or we have having the pseudodendritic lesions, that means very specifically I'm expecting viral keratitis. And BP is 140/90, pulse rate is 92, respiration 18, temperature 101. What is the diagnosis? Options are herpes simplex, bacterial keratitis, trigeminal neuralgia or herpes zoster. Now obviously we are ruling out the bacterial keratitis because dendriform ulcers I will not expect in the bacterial keratitis, that is for sure. Now, because they have involvement of all the three parts, all the three divisions of the trigeminal nerve. We have got frontal, we have nasociliary, we have lacrimal. So, it could be trigeminal. Now, why can't it be trigeminal neuralgia? Can you tell me? Yes, we are having a pain in all the three divisions of the trigeminal nerve. But will I have systemic features in cases of trigeminal neuralgia? No. Yes, then I will not have rashes. I will not have dendritic form ulcers. So it is not the trigeminal neuralgia. So simply you are left with herpes simplex keratitis and herpes zoster ophthalmicus. And the answer is pretty sure, I think. What do you say? Hutchison sign. Option A क्यों है गौरव? Why it is option A? Why do you think that it is option A actually? They are saying something like this. We have got the rash over the forehead. We have got involvement of the eye also, as well as the tip of the nose is involved. So we have the lacrimal pain. We have involvement of the tip of the nose. We have got involvement of this frontal area. Yes. Hello, Rahul. So, where do you get this Hutchison sign? Strict distribution on one side of the forehead. Where do you get the systemic features? Where do you get the rashes along with the pseudo dendritic ulcers that are dendriform ulcers? So, obviously, it is not herpes simplex. In the herpes simplex, we have got true dendritic lesions. We do not have the systemic features like fever and all. That is why the answer will be the herpes zoster ophthalmicus. I think this is a question where more often than not I get this doubt that why it is not herpes simplex and why it is herpes zoster. So I think it should be very, very clear. Is it clear to everyone? Is it clear to everyone why it is herpes zoster and why it is not herpes simplex? Yes. Is it clear to you, Gaurav? Why it is herpes zoster and why it is not herpes simplex? Everybody is pretty clear or not? Please let me know. Are you clear about it? Okay. Now let us see another question. Here we have got a 18 years boy who is coming to the eye casualty with the history of injury with a tennis ball. First question is, what type of injury is this? If there is a history of injury with a tennis ball, what type of injury are you expecting? Yes, ma'am, hai. Sabka yes hai. What kind of injury are you expecting with this tennis ball? My first question. On examination, there is no perforation, but there is hyphema. What is hyphema? My second question. Can you please? I could not get your question, Surabhi. Are you talking about superior oblique palsy? What is this hyphema? Second question. And then is your third question. They are asking you what is the most likely source of this blood? What is the most likely source of this blood? Yes. So first of all, whenever we have injury with a fist, with a ball, with a punch, it is always a blunt trauma. And obviously it is going with the question also because they are saying that there is no perforation. So if there is a blunt trauma, I will not have any perforation. Yes, sir. Then there is hyphema. What is hyphema? Hyphema is actually the blood in the anterior chamber. So when you are seeing the patient, you are seeing blood in the anterior chamber after the trauma. What is the most likely source of this blood? So whenever we are having this bleeding, you have to think about two sources. What is the blood supply of the uveal tract? So if you think about the blood supply of the uveal tract, we have got two circles. One is your major arterial circle, and another is the minor arterial circle, major arterial circle, minor arterial circle. Major is Another question, where is major present, where is minor present? And it is this major arterial circle which is the most common source of the traumatic hyphema. The most common source of the traumatic hyphema, whenever we are having the hyphema due to the trauma, it is traumatic hyphema. The most common source is your major arterial circle. So have you answered this? Where do you get the major arterial circle and where do you have the minor arterial circle? Two more questions. See, we can have a lot of questions from one question. Where do you have the major arterial circle? Major arterial circle is actually present at the root of the iris. Okay? And the minor arterial circle is present at the pupillary border. It is present at the pupillary border. We have got major arterial circle and we have got the minor arterial circle at the pupillary border. Clear hai? Yes, Chinmay is right. It is the root of the iris and at the pupillary border. ठीक है? Now, let us try to see one more thing. Yes, this one. Again, important question. A young patient is coming to you with the sudden painless loss of vision. So what are you thinking? Again, from the first day I am telling you, whenever we have sudden painless loss of vision, think about the posterior segment. Okay? We are thinking about the posterior segment. With a systolic murmur is there. Fundoscopy was done and they have given you the fundus image. Who will tell me the fundus image? What is this? Explain this fundus image. Can you see this one? This is a easy one, but it is very, very important. You can see a pale retina. So because you are seeing a pale retina, that means we have a occlusion of the main blood supply. But still you can see a reddish area here. Now, what area is this? Because you can see this is the optic disc. So that means this area is the macula, and inside this, of the size of the optic disc, we will have the fovea centralis. So fovea centralis continues to shine dark red with the other area pale. So that means a diagnosis is very clear. It is the CRAO, Central Retinal Arteriolar Occlusion. Now, what is the, yes, so what is the name of this sign? What is this sign? This sign is your cherry red spot. This sign will be the cherry red spot. Okay? Now, very, very important is the DD of this cherry red spot. What is the DD of the cherry red spot? Cherry trees never grows tall in mud and set. Now quickly write what is the meaning of this. All words please do write in the live chat. Let me see. Write what are the things that you are expecting in the cherry red spot. C for CRAO, T for Tay-Sachs disease. Now you can expect an integrated question here. We can have a question on Tay-Sachs and eye involvement in the form of cherry red spot could be there. Then we have got the Niemann-Pick disease is there. Then we have got G for gangliosidosis. Very good. T for, what is this T for? T for trauma. Which kind of trauma we are expecting? The blunt trauma. And what do we get in this trauma is the macular edema. Often we get question related to this macular edema because this is called as the Berlin's edema. This is called as the Berlin's edema. Okay? And what do you mean by this mud and scent? This is your metachromatic leukodystrophy. Metachromatic leukodystrophy, and then we have sand. This is your Sandhoff disease. Okay? Now one more thing with this G, we also have the Gaucher's disease. We also have the Gaucher's disease, and this Gaucher's disease is again important because it has the pseudo cherry red spot. Because it has the pseudo cherry red spot. So are you clear with this, everybody? What do you get in CRVO then? Very good. So suppose I say that CRVO may we have cherry red spot. What do you get then in CRVO? What do you get in CRVO then? What do you get in Eales disease? Quickly write it. What do you get in CRVO? What do you get in Eales disease? Then what do you get in sickle cell retinopathy? I am making you remember these things because they can be asked in your integrated questions. What are the appearances that you get? Please write in CRVO, Eales disease, sickle cell retinopathy. Okay. Then what do you get in cases of diabetic retinopathy? Diabetic retinopathy may what do you get? Now obviously when I'm saying diabetic retinopathy, you have to specify whether I'm asking about the NPDR or whether I'm asking you about the PDR. Okay? Then what are the signs that you get in CSR? Then in CME, what are the signs that you get in CSR, CME? Then what is the specific thing that you get in ARMD? You have to remember this also. So let's start with the CRVO. What is the fundus finding in cases of CRVO? Very good. So in the CRVO, very good. I will get the splashed tomato appearance. Splashed tomato appearance. Then I will also get the cotton wool spots. So you will get these things in the question. Cotton wool spots you will get because of the hypoxia. Then you will also get the tortuous veins. Tortuous veins we will be getting. Then Eales disease may what you are going to get? Yes, so Eales disease may basically we are going to get the vitreous hemorrhage. It is the most common cause of the vitreous hemorrhage, especially in the young patients. Okay. Then what you are going to get in sickle cell retinopathy? Any person coming to you with the sickle cell retinopathy, you will have the C fans. Candle wax dripping kahan milti hai? You are going to get the C fans, and you are also going to get the angioid streaks. Okay? Then what do you get in cases of CSR? What are the important signs that you get in CSR and CME? Chin mein candle wax drippings kahan milti hai? Candle wax drippings. Candle wax drippings actually we get in cases of sarcoidosis. So always remember, don't confuse. Sarcoidosis mein milti hai. What is the important sign that you get in cases of CSR? Sarcoid candle. Yes. CSR and CME mein. CSR mein you get the mushroom pattern, also called as the umbrella pattern, or it is called as the smoke stack pattern. सॉरी, नो प्रॉब्लम, सॉरी कहने की जरूरत नहीं है, वी आर ऑल हेयर टू लर्न, ठीक है ना, कोई प्रॉब्लम नहीं है. It is good that you make a mistake here. Mushroom pattern, umbrella pattern, or the smokestack pattern. What is the other pattern? Or we also get the ink blot pattern. We also get the ink blot pattern, or which is also called as the enlarging dot sign. Enlarging dot sign. Normal fundus क्यों मिलेगा CSR में? What is the fundus that you get in CSR, Avinash? In cases of CSR, the fundus में we get the circular ring sign. Circular ring, मैं लिखती हूँ. In cases of the CSR, we get the circular ring sign. This you are going to get where? This we are going to get in cases of the fundus. ठीक है? If I am doing the FFA, then I am going to get either this umbrella pattern, or mushroom pattern, or the smoke stack pattern, or I can get the ink blot pattern, which is also called as the enlarging dot sign. ठीक है? Then if I am having the CME, then what about CME? What are the things you are going to get in cases of CME? Yes, ma'am. ठीक है? Detected by FFA, very good है. CME में what is the sign that you are going to get in fundus में? We get the honeycomb appearance. In the fundus, we are going to get the honeycomb appearance, and when we do the FFA, what is the sign that I get? What is the sign that I get in FFA? FFA appearances are also very, very important. We will get a typical flower petal. Flower petal appearance. We get the typical flower petal appearance on the FFA. Yes. Yes, Pooja and Saurabh, correct hai. Then what is the typical thing that you are going to get in ARMD? What if I have a dry ARMD, and what if we have a wet ARMD? If a person is having a dry ARMD, what is the diagnostic thing that you have? By seeing that, you can say, yes, it is a case of dry ARMD. What is the thing that you are going to see in cases of dry ARMD? Acha, tell me one thing more. Next Friday will be just one day before your examination. What are the things that you want me to revise on the last day? Please let me know. We can plan a session where we will be revising those things that you absolutely want just one day before. So we can revise those things. Yes, exactly. It's drusen's. So we will be having the drusen's in cases of the dry ARMD. That is very, very specific. In the wet ARMD, we will have choroidal neovascular membrane. Choroidal neovascular membrane. This is called as the CNVM, choroidal neovascular membrane. ठीक है? Now, what about the NPDR and the PDR? What about the NPDR and the PDR? What are the things that we are going to have in cases of NPDR? If a person is having a non-proliferative kind of diabetic retinopathy, what are the things you are expecting in fundus? में पहले बात करते हैं. What are the things that you are expecting in the fundus? So if you are having a non-proliferative type, the things that I think will be coming next day. Okay. So I'll frame certain things that I think are most important for the exams. I cannot claim that that will come in the exam, but that are most important for the exam, I'll keep it. Yes. So it is your micro aneurysms. ठीक है? So first thing, I am expecting microaneurysms. Then we will have the dots and blots. What kind of exudates? It will be your hard exudates. Dots and blots hai, hard exudates hai. Then what else we are expecting is your irma, small AV shunts. We are going to have small AV shunts. Okay. Irma, that is your small AV shunts will be there. What else? NPTR में microaneurysms हैं, hard exudates हैं. Anything else? Then we will also have the venous changes, venous beading, venous loops will be there. What else? In cases of the PDR, what are you expecting? One question on squint. Should I take the Park 3-step test or what question you want on squint? PDR mein, I will have all these things plus we will have the neovascularization. Plus we will have the neovascularization. So what about the neovascularization? Where do you have the things? Just a second, guys. Yeah. So we will have the neovascularization. Now this P53. Hi. Neovascularization on the disc. So NVD we will have and we will also have the NVE. Now because of this neovascularization, we are also going to have the vitreous hemorrhage in the patient. Okay? And what do you expect in cases of the hypertension retinopathy? What are you going to expect in cases of hypertension retinopathy? Okay, so I'm noting down all these things that you people are telling and I will take all these things in the next session. Okay. Hypertension retinopathy mein we will have angiospasm. Thinning of the blood vessels will be there. Plus we will have the flame-shaped hemorrhages. Along with this, we will also have the soft exudates. So these are the things that we are going to have in hypertension retinopathy. Okay. Then esotropia types. Okay. Now let me tell you one by one. First of all, we were having a query about optic neuritis versus papal edema. ठीक है ना? Optic neuritis versus papal edema. So fundus appearance की बात करते हैं. So if I have optic neuritis, I can have three kind of appearances. We can have the papillitis. We can have neuroretinitis. We can have retrobulbar neuritis. So I have comparison of four things. If I have papillitis, we will have optic disc edema. We will have hyperemia, reddening will be there. And we will also have the blurred margins. Optic disc edema, hyperemia, redness will be there and I will have blurring of margins. This is just papillitis. If I have neuroretinitis, then we will have the macular star formation. So this is another fundus of optic neuritis. If I have retrobulbar neuritis, then we will have normal fundus. So these are the three things that I can have as a fundus appearance. Now, what if the patient is having papal edema? Now, first of all, if the patient is having the optic neuritis, I will have the unilateral changes. While in cases of the papal edema, it is always the bilateral changes. Then it is passive. You do not have the active optic nerve disease. Now, this papal edema is actually due to the raised intracranial pressure. So, when I have raised intracranial pressure, it is actually this which is leading to the exostasis. Somebody is asking me, I think, about the exostasis also. So there is actually exostasis. So exostasis means there is a stasis in the flow of exoplasm. Due to this, we can have the retinal hypoxia. So what is happening? There is actually, stasis. Both kind of changes are occurring. We have the mechanical changes also. We have the vascular changes also. So mechanically, we will have the Paton lines. Paton lines means we are having the folds. These folds can be present in the retina, or we can have in the choroid also. While if I go to the vascular changes, then I get what? I get actually the enlargement of blind spot. Enlargement of the blind spot. Why? Because what is happening? There is large amount of edema. It is actually 7 to 8 times optic disc edema. We have got 7 to 8 times optic disc edema. So when I have so much amount of optic disc edema, the size of the optic disc is enlarged. That is why it is called as enlargement of the blind spot. Are you clear, Avinash, now? Optic neuritis patient can also have papal edema. No, see, anything can happen in this world, but they will not give you such a question. They will give you a question which is of your level. Why will they give a question where optic neuritis and papal edema both are there if they want you to choose one? So optic neuritis will take place in entirely different perspective. Papal edema will occur in an entirely different perspective, where patient is already having the raised intracranial pressure, and he or she will also have the features of raised ICT. So you don't have to confuse between the two. Okay. Now regarding the squint, somebody was asking me about the head tilt. See, head tilt actually takes place in two muscles. One is your superior oblique and one is your lateral rectus. Okay. Now, this head tilt which takes place, it is actually compensatory head tilt. Head tilt always is a compensatory head tilt. Compensatory head tilt takes place in the direction of action of the paralyzed extraocular muscle. So because the muscle is not able to move, so there is a misalignment of the visual axis. So our head tilt is tilting to compensate for the action of that paralyzed muscle. So it is in the direction of action of paralyzed muscle. So what is happening? Suppose we have a problem with the right lateral rectus. We have a right lateral rectus palsy. So the head tilt will take place in the direction of action of this paralyzed muscle. So if I have a right lateral rectus palsy, head tilt will be right side, because its action is right, towards the right side. But if I have a right superior oblique palsy in my patient, now what is the action of the superior oblique? Because it's an oblique, so its first action will be torsion. And we know that superiors are intorter, so main action is the intorsion. Then O for oblique, O for opposite. So this will go into depression. And we know RAD, matlab rectile adductors. So this will cause abduction. Okay? So what will be the action of this right superior oblique? It will be going inward. So it is going towards the left and it is going down. So basically its action is on the opposite side. So compensatory head tilt will also take place opposite side. So here I will have left side head tilt. That means in general I can say that in the lateral rectus we will have on the ipsilateral side same side head tilt. While in cases of the superior oblique or in cases of inferior oblique, it will be contralateral side. In cases of superior oblique, it will be contralateral side, opposite side. In cases of the lateral rectus, it will be ipsilateral side. So tell me if you've understood this, why in cases of the lateral rectus, we are having the head tilt towards the same side, and in cases of superior oblique, it is the opposite side. Are you clear with this? Today we have done a lot of things, lot of signs which are important, which should be on your spinal level. You should be able to memorize them, recall them. And as you see these things, they can come in the form of integrated questions. And as I always say, please give a special preference to your fundus images. We have discussed them, we have seen them many times, and today also I have discussed these things. Please have a look on the last day. We are meeting also on the last day, and as you people said, I will be coming up with many small topics which are very important for recalling next day. But please have a look on the fundus images. Definitely you are going to get the questions on the fundus images, and especially the diabetes and hypertension, the CRO, the most prominent one, are obviously the most important one. So, okay. So I think this is all for today. Please keep on studying. Don't lose heart. Don't get depressed. And as I always say, I'm just a message away. Whatever is your problem, please do let me know. I'll be coming up with the most high topics on one day before, and anything that you want me to discuss, you can also message me. So thank you. Take care. Goodbye. And happy ophthalmology.